is the interplay of multimodality imaging in breast cancer management. And the moderator is Dr. Janki Dharmarajan. I would like to invite her. She is the Senior Consultant Radiologist, Breast Imaging at the Lizzie Hospital, Kochi. And she's in charge of breast imaging and interventions. And I would also like to invite the panelists. So I would like to invite Dr. Dilip Vaisar, who's the Assistant Professor of Breast Surgery at the Tata Memorial Center, and Dr. Mukta Mahajan from Apollo, Chennai. We heard her yesterday as well. Dr. Smriti Mulani from PD Hinduja. Dr. Ayushi Sahai, who is the professor and pathologist from TMC as well. Dr. Tabassum Vadasadawala, who is the professor radiation oncology at TMC. Dr. Neeta Nair, who is the lead surgeon in breast surgery at Apollo Hospital, Navi Mumbai. Dr. Namita Mohindra from SGPGI. Dr. Trupti Kulkarni, who's a consultant radiologist and specialist in breast and...
No, I'm not his cousin,
we've
but
met her
I'm
many
just one of the
times
Nairs in the
yesterday.
system.
Nightingale Hospital, Dr. Nikita Chotai again.
Beautiful pictures for that. We present, when the surgeon opens it, they have a beautiful idea regarding what they are going in. So it's basically a, we all have to work together. Okay. Yeah. So coming to case one, so the 18 can take it. This is the 18. This is a 42-year-old lady who presented for a short-term interval follow-up of right breast masses. Actually, the inside story was she got a thermography done that detected something on the left side, but she got an ultrasound and mammography. They found out something on the right side and she was on follow-up. So she had a prior ultrasound elsewhere that showed probably benign right breast masses, but only the reports were available. She didn't have any palpable concern, but she also had bright yellowish nipple discharge on expression. So, team A, what would you like to do? The radiologist? She's 42. Yeah. Okay. Yeah. Yeah, that's right. We'll start off with the mammography.
I mean, hopefully the lesion was hypoechoic and solid appearing, and so...
Yeah, we had only the report. So, report was mentioning a solid hypoechoic mass on the right side. Okay, but since we didn't have any mammography images for comparison, we proceeded with the mammography. And this is what we had.
So extremely dense breasts. I don't see any obvious masses, no architectural distortion, so a negative mammogram.
Okay. Yeah. So it didn't give us too much of information. We just see one thing we have to remember that it's actually during my career I found out that even though I was driving the high end that Mercedes Benz, but in between I had to settle down for 2D for some time. But that is when I realized the problems that most of our colleagues are facing. So that's why I just put the 2D images, and now again it's a high end machine, but still most of us, almost 95% of us are still dealing with the 2D images. So whatever we are protocols or whatever consensus we are making, it should be kept, all others, the majority should be kept in mind whenever we are formulating anything. Okay, so mammography did not show anything. So next step?
Ultrasound of the right breast to look for the mass which
masses,
follow up.
So since we had the image, so one more thing is normally outside ultrasound, they will mention the lesions, they will mention the clock position, but distance from the nipple is most often still not followed. So please make sure that if the patient, if coming back to you, it's fine, but if the patient is going to some other person, make sure you give a correct address to the lesions. It's very, very important. So she had heterogeneity dense breast, no suspicious lesions, and prior ultrasound had documented 3 masses. I was able to find all 3 masses, and then they were stable. So 6 months stability is achieved. Now, would you touch the left breast also?
It depends on how suspicious was the lesion which was found on our targeted ultrasound.
No, but right was okay. All 3 masses were there, they were safe.
There's a fair benefit of doing supplemental ultrasound in this case because of the background density.
Okay, that's fine. So Dr. Yojana had very well taken that, okay, but the benefits of the supplemental ultrasound for dense breast. And this is what I found out on the left, non-palpable. So, suspicious, what do you think of it?
Yes, so it has all the BIRAS descriptor for a suspicious lesion. So I would like to biopsy this further, although this is, and there's a solitary lesion on the right. The right side is not suspicious.
Right side, all three masses were stable in size
Okay.
as compared to the prior study, and they were probably benign looking.
Okay. So I would definitely like to biopsy this.
Yeah, and there is a lymph node.
Based on the cortical thickness is 0.3. It's not really screaming out that it's abnormal. I would just first biopsy the mass and then take it from there.
Okay, so considering the fact it's a dense breast, would you like to get an MRI done first or biopsy done? What does the protocol suggest?
I would stick to doing biopsy first.
Okay, so that's what I did, and these are the elasto images. So definitely slightly on the higher area. So even though it's slightly difficult, but most of the, especially with the shear wave, I am getting reasonably accurate images, but still I cannot 100% go by the shear wave elastography, even though means I'm still in the study phase, like we are just correlating the HP with the HP findings. So definitely, even though the mass appeared soft, this is the kind of that blue mass that Dr. Bar was describing. So the mass was blue, but actually there was some architectural distortion. The surrounding desmoplastic reaction was there, and that is definitely hard. So went ahead with the biopsy. Now another thing is, before biopsy, would you like to refer the patient to the surgeon? Because once we do the biopsy, what happens is we had an in-house surgeon. That's why I'm talking. So if we don't have, that's a different issue.
It's a good practice to have a clinical examination as well in the beginning, because it then everybody's on board, and in case this is suspicious, the discussion about what next can begin right after.
Okay, so what would the surgeon on the team suggest?
I would definitely like to do a clinical breast examination.
Okay. So we felt it was non-palpable. So in that case, what would you tell the patient? How will you? That because you should also convince her regarding the biopsy. So what will you do?
So I would like to convince the patient that it's sometimes the lesion may not be palpable but still suspicious. I would have counseled her for a biopsy.
Okay, so that's good. So now the radiologist. Yeah, sure.
Just different practice from the UK. So I would like to add that if this was a screening patient, then the radiologist would be involved, and I would proceed to do the biopsy. I would not waste the surgeon's time at that point. When the biopsy result comes back in a week, this will be discussed in the FPT. My surgeon would be present there, and that's where it would be, okay, over to the surgeon now. So utilize everybody's time appropriately is I guess, part of the take-home message.
Yeah, but sometimes there might be some post-procedure induration might be there. So what was totally non-palpable. So even if the patient is developing a hematoma, so that just feels like a palpable lesion at the end of. So it depends on the. So usually, if the surgeon is available, surgeon is free, within half an hour she'll just go see the surgeon. By the time we prepare everything, so it all depends upon the institution practice. But definitely, from my practice, I felt that a surgeon palpating the breast initially, it adds up to the final outcome as well as how the patient takes it, because she knows, okay, there are two people involved. So
if you're working in a setting where there's a one-stop clinic,
Yeah.
then you have the facility of everybody being there on board.
Right.
But if you're working as a standalone a breast imaging center, then it's completely fair, to have proceed with the biopsy and then
right,
refer
okay.
further.
So it's all institutional variation, but practices, they do differ, but we have to make sure that the patient gets the best outcome, because this might be potentially breast conservation surgery. So that is why I would like to involve the surgeon also upfront. So that is one of the reasons. So what we did was, I proceeded with, after the surgeon examined her, I proceeded with ultrasound guided core biopsy. And what would the pathologist, would she like to have some additional tests?
Yeah, as per this report, there seems to be an infiltrate of atypical cells which are low grade in morphology, and there is some desmoplastic stroma as you saw on your radiology imaging also. So I would like to proceed and confirm with the ERPR and HER2 also in this case, as well as I don't think they have mentioned query lobular, so E-cadherin, if there's enough number of cells, that can also be done.
Okay, so since we are suspecting E-cadherin, so that is why the next step, we got an MRI done, just to make sure that it is unifocal, it's a dense breast. Is it okay, team A, like?
So there is a focal lesion which is relatively brightish, at least on the STIR images, and it appears to be restricted as well. We don't have the ADC images, but it looks pretty bright and probably restricted.
Okay, yeah. So on ADC it appeared dark, even though I don't have the exact values, it was dark on ADC. So now I was able to confirm that this is a unifocal disease. So I told the surgeon, and this is the post-contrast images. again brightly it is lighting up on the first pass. So, and the initial setting I proceeded with FNAC of the lymph node also, and that was showing reactive cells. So when I do the biopsy, I always make sure that I do FNAC of the lymph node also. If there's even focal cortical thickness of 3 mm or any diffuse cortical thickness of 5 mm, I always make sure I proceed with the this one FNAC. So there was, it's actually persistent enhancement was also present. So what next now? And yeah, okay, now I'll say, so what would the surgeon do now? It's a non-palpable lesion.
Non-palpable lesion, in our institute in Tata, we do a sonolocalization, ma'am, where it will be easier for us to excise it. If in case, if we are not able to accurately sonolocalize it, a wire lock.
Okay. So this was a non-palpable lesion quite, yeah, so we went ahead with a biolocalization, and also along with that sentinel lymph node biopsy was also done. So, and once the procedure is over, always it's the radiologist's job to make sure that we proceed with, we have to make sure that the lesion that was detected on imaging is out. So the loop which started with radiology has to be completed with radiology. So till that time we have to make sure that the specimen is out, okay, the lesion is within, then we call up the surgeon and tell them, okay, you've done a good job, the margins are clear. Okay, and this is the final HP.
Yeah, so here I think your biopsy findings are confirmed. There is a invasive tumor, and in this it looks like it's reported as a breast carcinoma, no special type. It is low grade, and no other adverse features, LVI, PNI, no DCIs as well, and the nodes are negative.
Okay, so now it's
And the next, of course, again, as I said, biomarkers, we would have done on the biopsy itself as per practice in Tata.
Yeah.
But if not done there, then of course in this it would be done, as well as if it is low grade with nodes negative, MIB Ki67 would be helpful.
Okay, so Ki67 was low grade, it was just 10% initially when we did on the other sample, and E-cadherin was negative. So there was some insurance issue. So she told she'll get admitted and get all the stuff done. So insurance is a big actually issue in India, to be frank. So most of the patients, what they prefer is they try to get admitted for biopsy. So probably we busy as a team, we can give our suggestions and ask because even mammography should be covered. Ideally, if the patient has got insurance, what I personally feel is even the mammography has to be covered. So at least the ladies, they know we are spending something, means at least. So that we have to put up agreements, but it needs a lot of workup, lot of effort has to be done from the society as a whole. Yeah. So this lady. So now what further? What will be the recommendation?
Biomarkers, Ki67.
Yeah, biomarkers. Yeah. It was luminal A and E-cadherin was negative.
Yeah. So no other adverse features, and the Ki67 you said was
10%. 10%.
So yeah, luminal A and all the margins negative. Distances from margins, I assume are all
clear margins. Margins were
yeah.
clear. Yeah. Okay. Now for her, what will we say? This is the last one. Yeah. Ki67 they did.
ERPR are strongly positive. The
Yeah.
scores are 8 by 8 and HER2 negative, and Ki67 is actually quite low. So that confirms that it's a low grade IBC, no special type. The E-cadherin appears retained. So IBC, no special type, grade 1.
So she just came for follow-up of the lesions on the right breast. So it's up to us to make sure that she doesn't have anything. So dense breast, always we have to be careful. And she opted for the treatment part.
Ovarian suppression and endocrine therapy.
Okay.
No chemotherapy.
Radiation has to be, yeah, that's true. So in these cases, would you have preferred that that some short dose or something, that intracavitary radiation would that have worked out well in this case for it?
No, I don't think so. But I mean, she's extremely low risk. But the data on 5 fraction fast forward, that would be the thing I would be more comfortable.
Okay. Thank you. So now, what we have seen in the case of screening detected mass in dense breast, we have seen the role of mammography, the role of supplementary ultrasound, guided biopsy, and we have to make sure that concordance has to be given. It's actually the radiologist's job. So even if the surgeons are not getting some concordance, ask the radiologist. You're doing a biopsy, give me the concordance. So it is the radiologist's job to give the concordance. We have to we help in staging to confirm the focality, guided localization, and specimen ultrasound to complete the loop of screening cancer. Now
May
coming
I
to
say something?
yeah, sure.
I had a query that initial biopsy suggested a possibility of lobular, but do you think your subsequent MRI showed something that would be a lobular, or would it be a ductal in your opinion?
No, it was a unifocal mass
Exactly.
because usually
And
with
very
lobular,
circumscribed,
it was
very thin
circumscribed.
margins.
Yeah, so even I was also asking, so pathologist, so initially I saw the cells, but then it can be maybe a small mixed type also. She was saying that whatever course I got, it is possible, but in the final one, she could not find anything. So always we have to be friends of the pathologist.
Because it was persistent enhancement.
Yeah, persistent enhancement
washed
was there,
out,
yeah.
So that goes. You were saying something.
Yeah, you.
So I just wanted to say, this is a typical case of screening with a grade 1 cancer, which is incidentally found. And in fact, we keep debating this. Are we really saving lives, right? There's a small trial in which we are actually screen-detected cancers less than 15 millimeters are being subjected to either a stereo or an ultrasound-guided vacuum-assisted excision rather than being subjected to surgical treatment. And those are being followed up for forever, really, and to see if we can just stop with the vacuum-assisted excision rather than treating them with everything.
Yeah, but I guess those will be the patients who would be elderly, not 42 years.
No. Screening patients. So of course, our screening patients are from age 50 onwards.
Yeah.
But it's
So
part of the screening, and it doesn't have to be.
would not be.
She wouldn't be part of the screening. But the point that I was making was, if this was a screening. Yes, but the surgery would they wouldn't really have open surgery.
But what about the lymph nodes? So how will the surgeon react to that? Like,
Well, that's the thing. With small cancers, with grade 1 tumors, they don't go for a lymph node.
lymph.
I think that's the data from the SOUND trial, which has basically told you that if you have low-grade T1 tumors, you could potentially avoid just do an axillary ultrasound. I'm going to throw out a word of caution. You're looking at, and this is basically to students in the group and on a concept of oncology. What you hear on stage, the people that you're hearing are experts in the field. That's not what's the reality of the Indian population. If you have a radiologist who's really good, does an ultrasound, FNAs the lymph nodes, is used to seeing breast oncology, yes, that's the way forward. As a routine, could we just use an ultrasound? We're not there yet. We hope to get there someday, but we're not there yet.
Okay, so now we'll move to the case 2. This was a 50-year-old female. She had recurrent episodes of hypoglycemia, early satiety and bloating. She was worked up for CT abdomen. They found a cystic lesion in the tail of pancreas. So, team B.
Yeah, so we go ahead and do a mammogram because we find something in the lower aspect of the breast. So we need a diagnostic.
Okay. So this is what we found out.
Okay, so it's not visible. There is no discrete mass. We'll go ahead and do an ultrasound to try and find it.
Okay, so based on the CT location, it seems to be very inferiorly located and probably could not be identified, could not be included in the.
Yes.
I told even the technologist told me she could not feel anything, so she did not include. So this was actually a non-palpable mass, incidentally detected on during the CT abdomen. Okay, and this is what the ultrasound images show.
Yeah, very suspicious looking mass. So irregular, hypoechoic, we would need to go and sample this.
Yeah, so these are the images.
Internal vascularity, it's stiff. So we'll go ahead and do.
Okay, and the lymph nodes were normal. So we proceeded with ultrasound guided core biopsy.
Yeah, so the core biopsy is showing, I think the impression is basically DCIS, which is cribriform solid papillary. It's a mixed type of DCIS, but low grade, I think the description seems to be low grade. The P63, and which is a myoepithelial marker, which is done to check whether there is any focus of invasion, that is positive. That means there is presence of myoepithelial cells. There is no invasion in the cores that have been sampled, and the ER is diffuse positive in the DCIS areas, again indicating there is clonality there. So we are not looking at hyperplasia, UDH. We are looking at diffuse positive, low grade ER positive DCIS in the biopsy, and at least in the biopsy there is no evidence of any invasion, and as they have advised, it would be recommended to rule out invasion on an excision specimen since it has not been identified in the biopsy.
Okay, so in these cases, we are not able to see the mass on mammography, so we cannot comment upon the calcification. So how would the radiologist proceed now?
I think because on the ultrasound we had suspicious features, we showed there was internal vascularity. Most of the DCIS would be high grade if it's vascular. We should go ahead do an MR as well.
Okay. So this is what the we did MRI as a part of staging because we are thinking in terms of conservation
Staging as
surgery.
well, yes.
So these are the T1, T2 stir. This what.
So it is bright on the DWI. I'm presuming it would have been dark on the ADC since you've written there is
Yeah.
restriction on DWI. So now it is unifocal non-mass enhancement that we are seeing here, and there is no lymph node. So we would, since we are seeing it on ultrasound, we can target on the ultrasound guided.
Okay.
By
So,
localization.
what would the surgery, like kind of surgery, be offered to the patient?
Again, she's amenable for a wide excision with sentinel node biopsy. And I think the fact that it's located in the very close to the inframammary crease, she may need a little bit of cosmetic correction there. But a wire localization would be advised, especially because it's a little diffuse, it's non-palpable. And of course, this is a concern where, despite the fact that there are no calcification, you may still want to send it down for a specimen imaging because DCIS tends to be very diffuse and can be multifocal despite this.
I think for the trainees in the room, the important thing here is that breast is a review area. And if you find a breast lesion, you need to flag it up such that if there's something going on in the rest of the CT, for example, there's a lung cancer going on, the breast will get missed if you as the radiologist don't flag it up. And you have to take it to its logical conclusion in terms of it going to the breast unit, etc. That's one. The second thing is about the pathology. If my pathologist said, I would want more tissue, which is something that they do say from time to time, this is one of the cases where, and they say, well, it can get upgraded. It's one of those that I would subject to a vacuum-assisted biopsy prior to the surgery. If I can upgrade it, then it will help my surgeon decide on a more definitive surgery. So those are the two things I can think of.
So, also, just to point out exactly what Ayushi said earlier, is this is something that's come up as DCIS only on your core biopsy. That needs to be informed to your pathologist when it's going back. So because they section it very differently when it's just DCIS looking for an invasive component versus when one has an invasive component on the biopsy already.
Okay, so if it is, since they are given it as DCIS, so is it that, do we have to address the sentinel lymph nodes also in the same setting? Any size criteria?
So I would be honest is that one continues to do it just because you wouldn't be able to necessarily go back in as easily. For a palpable lesion, one would always do some sort of axillary staging. For a non-palpable low-grade DCIS, could you choose not to do a sentinel node biopsy? The answer is yes. But again, your patient needs to understand that if you pick up an invasive component on this, one would need to go back in and stage the axilla.
So is there some study that shows that the lymph nodes, like in case of DCS, we are operating, but the lymph nodes are normal on imaging. So now we have imaged her with ultrasound mammography as well as MRI. Imaging is normal. So can you just directly radiate the axilla in case she's opting for a breast conservation?
You don't radiate the axilla without staging it. It would need to be, the option to radiate versus operate would be if your sentinel node came back positive, then could you operate, could you radiate is where the question arises. But to stage the axilla, either you use ultrasound, which is how the sound study did it, or you operate.
In her case, if everything is negative, axilla won't be treated.
At all,
Okay.
exactly.
Right. Okay, so we planned her surgery, everything was planned just before 1 day prior to the surgery, the patient told, I cannot come for radiation, I want my breast out. So,
I honestly think that's a patient's personal choice.
Yeah.
Choosing to opt for a mastectomy versus obesity is patient decisions.
so sometimes we do a proper workup thinking that okay, the patient may, but ultimately at the end of the day, like it's the patient who gets to decide, because all the options have to be given to a patient. So this is something, breast non-palpable lesion incidentally detected during CT chest. So whenever we are the ones who are doing body imaging, please make sure that you try to see the breast also. So already we have collected almost 56 cases now. Or the CT detected lesions, we are making a list of it. In the past 8 months itself, I got almost 56 worked up lesions. So it's much more common than what we are seeing. So definitely all of us, we should make an effort to, whenever you are doing this body imaging, make sure that you have a look at the breast also, so that the cancers are not missed out and you end up saving the life of a patient. That is ultimately the point from here. So she opted for mastectomy with sentinel lymph node biopsy, and
Yeah, so here the final histopath report on the mastectomy is also showing DCIS only with no invasion, which is confirmed on marker myoepithelial cells is CK56, which is positive at the periphery. It is again a low-grade DCIS, which is ER and PR positive and HER2 negative. Now, as Dr. Neeta said, so in such cases, even if we take initial sections, the representative sampling, and in that we get DCIS only, and the biopsy also it was DCIS only, we are not finding invasion. As per protocol, we will go back to the specimen, we'll sample the DCIS entirely to rule out there is no invasion anywhere, because that will markedly change the prognosis. So we will, the pathologist requires that the whole DCIS has to be sampled, and that is the utility of having an excision in such cases, because invasion can be very focal and can be missed on initial sections. So if we are not finding it, we go back and sample everything entirely and confirm that there is no invasion, and we do markers on as many sections of wherever we find any suspicious foci. We go and do markers to for the myoepithelial cells to check whether there is no invasion in this, confirm that, and then accordingly the report is made. So in this again, the features of DCIS, which seems to be low grade, ERPR positive, and there is no invasive tumor.
okay, so in this case, I just, one more thing, just before the patient went for the surgery, I just called her, I marked over the skin, because it was so much, it was located so down inferiorly, so I don't know exactly where the surgeon will be putting the mark, but still I wanted to make sure that the lesion comes out. So I just called the patient, made a mark on the skin, and then sent her to the OT. So it was a totally non-palpable lesion.
One more thing, I think that the margins have been marked, have been reported free, and the deep margin has been shown to have a clearance of 0.2, which is, just at the border of comfort for DCIs.
Yeah, but this was already somewhere sitting on the upper abdomen, and they couldn't probably, so incidentally detected breast masses, a diagnostic mammography and thorough workup has to be done. And this is just a case that shows a non-palpable, non-calcified DCIS. So sentinel lymph node biopsy has to be performed in DCIS, and then how to follow up the patient. So for her, I think just what do we follow up, like what will be the next recommendation for her?
So I would think
imaging recommendation.
So the imaging recommendation, she's a 50-year-old lady, she's got screen detected DCIS, she just goes back into routine screening, which is a mammogram once in 2 years for the opposite side. I don't think we've particularly changed her risk with a low risk DCIS being picked up.
Okay, so that's fine. So with that, we'll go to
Do it yearly, so she would have
An-
contralateral, yes, but
annual
she would have it
mammography,
yearly
yeah.
for 5 years.
Okay. So this is a case 3. So a 30-year-old lady had presented with palpable progressive left breast lump of 4 months duration. Clinically, it was a painless, hard lump with restricted mobility. So the general surgeon had referred her to me. He felt it was something suspicious. Her last childbirth was 8 years ago, because always whenever young ladies to come, I make sure, I ask them when the last childbirth was, because the incidence of granulomatous mastitis is quite common in India. So if it is within 6 years, I always make sure that could be one of the possibilities. So always last childbirth I do ask in ladies. And she was having acne vulgaris on treatment since 1 year, no significant family history. So how will you proceed? Teammate, radiology?
So she's 30 years of age with palpable concern. I'll proceed with targeted ultrasound first.
Yeah. So we did an ultrasound for her. This is what the ultrasound showed.
So it's an irregular hypoechoic mass of parallel orientation, has some angular margins as well. There is intense intralesional vascularity. It's at 12 o'clock, 2 centimeter. Overall size must be around 2 or more.
Yeah, 2.5 almost, yeah.
Yeah, and the axillary lymph node is also showing diffuse increase in cortical thickness. So the next step would be, at this stage, I would complete her diagnostic evaluation with a mammogram, bilateral breast mammogram, and Yeah, so I agree, extremely dense breasts, and there's nothing else suspicious. We do have to proceed with a biopsy.
Okay, and this just the images. So
heterogeneous strain pattern really here.
yeah, heterogeneous staining pattern, and we could see that in some areas where not the waves are not able to go through. So the surrounding was quite this one. It was vascular. In some areas, the waves are not able to travel through. So I don't know the exact significance of it. It's a heterogeneous pattern. So what we did, so we did ultrasound. FNAC of the lymph node showed reactive hyperplasia. I proceeded with the FNAC of the lymph node also, and this was the HPE.
Yeah, in this there is as per the description and the impression, there seems to be benign breast tissue with only sclerosis and some inflammatory infiltrate, and there is no malignancy here. So I would assume, given the radiological picture, that it seems to be non-representative.
Yeah, so I actually took 6 samples. Normally I take only 5, but here I took 6 samples and there were images, they were staring at me, okay, there are hematomas within the mass. So what will the radiologist do if you are getting this report?
So here, even the pathologist is not sure whether it's PASH. If the pathologist calls it confidently PASH, then I'm okay to follow this up. If it's very large and I think it's maybe heterogeneous, I may not have sampled the whole area, then excision is okay. So the size of the lesion in terms of PASH is very important, but if it is possibility of PASH cannot be excluded, it's better to excise.
Okay, so pseudoangiomatous stromal hyperplasia.
Pseudoangiomatous stromal hyperplasia, basically it's just one of the variants of the benign changes that you can get, wherein the stroma appears elongated, pulled out, little bit more cellular, and it's a lot of mimicker of fibroepithelial neoplasms. You can see it incidentally also in fibroadenomas adjacent to even tumors. You can see that. It's just one of the spectrum of benign changes that you can get, but which is sometimes worrying as a lesion in itself.
So there is actually
PASH is a benign stromal
it's a benign,
tumor, right?
it's
not a
benign
B3
stroma.
lesion. It's not. It doesn't have increased malignant potential. No.
And there is actually one very good article published by one of our faculty, Dr. Rupa Ranganathan. So I just referred to the images also, and it was looking very similar. But still, I was not very convinced. I told the surgeon, okay, you go ahead and remove it. Because
In my setup,
it is discordant benign. So I felt it was discordant benign. It was a very hard mass when I biopsied. So there were, even though the cores were good, but still I was not very convinced. It was too hard for comfort.
yeah. So in my setup, I would rebiopsy this. I would take more samples, and in fact, that lymph node, I don't like the look of that. I would core biopsy that lymph node.
Lymph node, I did FNAC, that came as reactive.
Yeah, but yeah, this is what I would do if I was in the MDT.
Yeah. So we proceeded with excision biopsy, and this is what it told.
Sorry, I was lost there. So it's on the wide excision. What is the T size of this lesion?
It was 2.3 centimeters.
Okay, so it's a grade 3. So that, I think that explains that the initial biopsy possibly has sampled the adjacent sclerosed area maybe, and the tumor itself was missed, because this is a proper grade 3 with a very, very high Ki67 labeling index. It is triple negative. It is, I think the closest margin is, close also. So it's a grade 3 triple negative with a very high labeling index, and the P63, I suppose that was done for myoepithelial markers, is negative. So it is completely discordant with the original biopsy, and this is the actual tumor, I suppose, what you were seeing in the images.
Yeah. So now wide excision has been done. So what is the next step?
But this
lymph node was not addressed.
Strange to have the first biopsy on core.
Exactly.
And then have this sort of.
No, for me at least, the pathologist, she discusses each and every case. Even the course also she will discuss with me before she signs off the report. So at least I know that she told me it is looking, it's looking benign only. I'm not able to find. And plus she did some markers for that PASH also. I think there's some, what is that marker? 634. Yeah, she did that. It was positive. So then, even though we didn't put it officially.
But it has to be It is, you can see it, as I said, you can see it around tumors also.
Yeah.
In the sclerosed areas around tumors, PASH, and
It
that
can
is an
be-
incidental finding, it can be there. So that might be the more hard sclerosed area that you sample, because it will have a little fibrotic stroma also. So
Okay.
that might be a reason, but the tumor itself that is not.
So that's, I think the point exactly that Bijal made is that PASH would feel soft. These are not hard tumors.
Yeah, it was. This
So
was
when
very
it is discordant, you need to address it either by a repeat biopsy or by an excision, so that you're sure that you have clinico-radiological concordance with that.
This is inflammatory also. There was some component of inflammation also.
Yeah.
So that also is, I mean, not the kind of picture that you were getting. That seems to be more of the adjacent tissue. And being a triple negative, there might be some inflammation in the surrounding breast. So that possibly is the area that is sampled. A triple negative with a high MIP, that might be a tumor infiltrating lymphocyte-rich tumor, and the surrounding stroma has been sampled.
Right.
That
So
would be my
this
guess.
so only thing is an extremely hard tumor. So I felt okay, maybe I wouldn't have hit the target, even though the image was showing okay, I got the target, I got the nice 5 dots within the mass, but still, despite taking best efforts, we can go wrong. So now further, how would the surgeon prefer to proceed now? Axillary lymph nodes, we did FNAC, that was negative.
If the operating surgeon has oriented the specimen, my pathologist has confirmed that all the margins are free, I'm okay with the lumpectomy, I'd only do a sentinel lymph node biopsy
Okay.
or a low axillary sampling. But
Okay.
if they're not confident about the margins or the orientation, probably I would again revise the margins and then do a sentinel lymph node or a low axillary sampling.
Okay, so then any staging, we actually proceeded with the PET CT also. So any role of PET CT in this?
I don't think so, ma'am. It's a T1 tumor.
Yeah.
I don't think so as of now. It's an operable breast cancer.
Okay.
Because
So,
in early breast cancer, the rate is around 2 to 3% having a metastasis.
but PET is showing the axillary lymph node to be bright. So anything?
Yeah, anyway, that will be picked up in our lymph node sampling or
Sampling.
sentinel lymph node biopsy.
Oh, axilla we have not addressed. It was reactive initially when we did the FNAC. But if PET is showing activity, would you be worried about it, or just radiation can be given?
No, we need to stage the axilla.
Yep.
We need to stage the axilla, for which either a sentinel lymph node or a low axillary sampling
And after
needs to
the
be done.
biopsy, maybe this uptake could be inflammatory also.
It can be
Though
inflammatory
your-
changes
yeah,
also.
Yes.
Yeah. So in this case, right now the patient is on chemo. So they told, okay, we will just proceed with the chemo first. So after that, they were planning the RT for her.
So here's my concern then, that if there was concern regarding this lymph node and you want to give the patient chemo first, then she should have had a biopsy or a core biopsy of that lymph node, because your entire staging changes now. Yeah, but
Yeah.
so but the
initially-
point, so because the FNA was negative,
Yeah.
now you're showing suspicion based on a PET, and you're calling her N1 just because of a PET. And a PET is absolutely,
Yeah.
I mean, I'm glad Sneha's
Yeah.
standing up, because we all struggle with this. So I have enough medical oncologists that choose to do no imaging of the breast. It's just a PET scan that happens with an ultrasound of the breast and axilla. And they come to us post chemo, and that staging is thoroughly inaccurate. So I think Sneha can address that.
Not the modality of choice for axillary lymph node staging. You might have false positives very often with PET, and so even if you see uptake on a PET scan in axillary nodes, I am not confident of calling it meth. You have to biopsy that node, but PET is not the modality of choice for axillary. PET is useful only for identifying intramammary or supraclavicular nodes. That's the end staging where PET will help you, and M.
It is basically extra axillary lymph nodes.
Yeah, extra axillary
Yeah.
lymph nodes.
Yeah.
Could I just,
Yeah.
And again, just to highlight how practice is different in different parts of the world. So, because this was more than 2 centimeters, I would have rebiopsied it. I would have put in a clip marker. This patient would have had an axillary core biopsy, and she would have gone for neoadjuvant chemotherapy rather than chemotherapy in our setup. And I would probably have even clipped the node to say, this is the node that I biopsied. Just to say, practice is different in different parts of the world. And the second thing is, as far as PET is concerned, no, we wouldn't do a PET. But just for the trainees in the room, you can have PET positive changes in the breast from 1 to 6% of cases. And there are various studies which quote from between 50 to 90% or 95% of these could actually be a malignancy. So if there's something that is seen on a PET, then you do need to look at it as an incidental finding. You do need to chase it in the breast and ensure that you find it and biopsy it.
Okay.
As an incident.
Yeah.
Because the earlier diagnosis was, core biopsy diagnosis was going towards PASH, so I'm thinking of stromal tumors and maybe fibroadenoma or fibroepithelial lesion. In that case, would you still do the VAB?
In this case, I would have
You would.
definitely repeated a biopsy. I might not have done a VAB. I would have
Repeat the core biopsy.
Taking more number of samples and spoken to my pathologist and said, you know that this is what it was last time. I'm still concerned. So,
Yeah, I think, but the final diagnosis was a total surprise. It's triple negative.
yeah.
Okay, because I was quite convinced that I'd hit the sample, but only thing is quite hard. So sometimes, or maybe wider core I should have used. This I used a 14G, so probably with the 12G it could have been better. Maybe I would have got more core. So just sharing the experience regarding what we have having. Okay, so we have seen the surgical management, medical oncology, radiation and follow-up imaging. And how do we follow? For her, do we need to get an MRI breast? And if so, when? Like,
MRI at the first instance, okay, I would differ with that because all the cases you've shown till now, all of them got an MRI done. I don't know if that's really necessary.
Okay.
One thing. The second, the follow-up, no, definitely not an MRI.
she's
Mammography
30 years triple negative.
That's, I think mammography with a complementary ultrasound should be sufficient, ma'am.
Okay. Do we have to check for a BRCA?
Yeah, definitely a BRCA testing will always be done.
Okay.
Then we'll plan her accordingly.
Okay, right. Yeah. So I think in that case, time is over. Or would you like to take one more case? One. Okay. We'll be very fast with that. So this was a 40-year-old lady who presented for baseline opportunistic screening mammography, and she told at least 4 members in her family have got breast and ovarian neoplasm. So no concerns, palpable concerns at the time of examination. So this is what we found out on mammography.
Heart sink breasts, right?
Okay. And on closer inspection, because I told that point of time I was having only 2D, so this is what I found out. The nice mass, fairly circumscribed margins, and this findings on ultrasound. So, team B.
Yeah, so it looks like a very irregular hypoechoic mass, which is taller rather than wider. It's causing architectural distortion. There's probably a little bit of calcification within it. There isn't any vascularity within, but it is a small lesion, and that's just Doppler. It's not elastography. So very dense breast. She could have further lesions. On elastography, it's a blue cancer, so it's probably very, very hard. And so I'm learning. Richard Bauer was very good.
Okay.
I do like elastography. So, so yes, biopsy that, but MRI perhaps.
MRI, because in view of the family history. So we did an MRI.
So on MR, you can see, and the MR experts are here, you can see that although the density is quite a bit, it doesn't really look like that, and there is some amount of background enhancement, but not so much as compared to...
This
oh,
one,
sorry.
Yeah, this one, yeah. These are the diffusion weighted. I think everyone is hypoglycemia.
In the foot.
Okay. Yeah, I'll show you that. Yeah, these are the images.
Yeah, okay.
Yeah.
Okay. So these are contrast images or non-contrast images.
These are contrast, yeah.
Yes. So yes, these are contrast images. And there isn't as much contrast enhancement in spite of the amount of glandularity. And in fact, here it doesn't even look as glandular as it did on the mammogram. So there's a unifocal lesion in the central right breast, and there's nothing else that I can see. It's in the upper central right breast. That's a T1 tumor, and I can't really see any lymph nodes with the limited coverage. It's restricted on diffusion-weighted imaging, being bright on DWI.
Okay, so now next step will be?
Oh, we already biopsied it, right?
No, now only, after that I proceeded with biopsy. Since she told there was a family history, that's why I thought I just had to be sure that she had only one lesion. So how much do you agree with that?
Yeah, okay. So yes, we would proceed to a biopsy and axillary ultrasound. We didn't find anything on that. We would leave the axilla alone.
Axilla was normal, yeah. And this is how usually I take. After biopsy also make sure that I'm showing that nice tiny hemorrhages within the lesion. So if the pathologist has not got it, also look, I've got an image which shows it. That should not be there because we have to be legally protected. So images are the only ones that can protect us legally also. So this turned out to be?
Yeah, so it's a grade 2 IBC, and Yeah, that's at least your malignancy is confirmed, yes.
Okay. Yeah, so this was, and IHC also we did.
So it is low ER positive. Actually, the tumor ER proportion is quite low, and the intensity is also quite low. Though the score is 4/8, it seems to be towards a low PR negative, HER2 negative, high MIB, with the grade 2 luminal B at least. But with the ER being negative, I would being low, I would be more towards review of the morphology also to see whether I would like to call this a grade 2 or a grade 3. In the BR score. Do we have a proportion or cutoff of the BR score that has been used, tubular and nuclear and
No.
this thing? So because the grade 2 can be because it was more of a tubular pattern also rather than the nuclear grade being low. So I would give more cognizance to the nuclear grade and the mitotic activity. So I would maybe, if I have a high MIB and a ER that is so low, I would just review the morphology once maybe. But yes, if as per your report, it is technically ER positive, PR negative, and HER2 negative with a high MIB, luminal beat at least.
Okay. So now, and meanwhile, we also got her BRCA done, and she was a BRCA1 mutation carrier.
So, I want to know which lab you went to that got you the report that quick.
No, actually, no, I called up my my pathologist, so we are good buddies, like you can say.
So again, once I would like to highlight that when you have such low ER scores and it is a BRCA positive, we prefer in TMH at least, these kind of low ERs, we always like to flag this as per the ASCO-CAP guidelines also, that they are more likely to behave as triple negative tumors rather than hormone positive tumors. And the patient's family history, BRCA positive, as well as I would be more towards grade 3 in this case. I mean, not seeing the slides, I'm again like, it's like asking you to review only the radiology reports,
true.
but so without showing the images.
That's true, that's true. I tried to get the images, but unfortunately I couldn't load them, so yeah. Because it involves a lot of legal thing, like if you want the images, you have to give them, pathologists don't give away the images easily, yeah? So. Okay, so this lady, she was adamant that she wanted a breast conservation. So we went ahead with a wire localization followed by specimen radiography, and this is what we had.
There is anything to add here? It is confirmation of your tumor and the margins free. There is no DCIS and there is no other adverse features, and the nodes are negative.
Okay, and we repeated the tumor markers. It turned out to be triple negative actually on the main specimen for confirmation.
So actually, we have a study here in TMH in which, in such cases, we have repeated the markers. So it is now well known that in sometimes in core biopsy, this little bit of low ER kind of positivity. That is because of more very good fixation practices as well as good antigen retrieval that systems that we are having in place. We end up picking this little low ER and all that. So it would be better to repeat that on the excision specimen to confirm that it is triple negative.
Okay.
With this kind of family history, it seems to be.
Okay, so thanks. That's a very important information. So anyway, we asked her to repeat. The pathologist herself repeated the ER. We didn't say anything, but final thing was a triple negative only for her. Okay, so for her, we have done a BCS. So, and the main thing is for the BRCA patients, how long do we have to continue screening? So they are into high risk.
The guidelines still tell you to continue till about 75, but the addition of MR, I think in the NICE guidelines is the MR is only till about 40 or 50, if I'm not wrong.
So this particular patient, given that she's BRCA1 with the risk of developing breast cancer between 55 to 79%, she's one of those, she has 4 relatives with breast cancer. She's one of those who would go for bilateral mastectomy, prophylactic mastectomy. So we would screen. Yeah, if she opts not to, then you're right. She would go for yearly MR and mammography up till the age of 50, following which it would just be in the screening. Yes.
So like 50, so if the patients are coming confidently, we can tell them stop at 50 or?
Well, that's the thing. I always tell them, your risk of cancer is not going down. It's your choice. No, we do tell them, and most times they do want it continued, and although it's not in the NICE guidance, we do continue with the yearly MR. It's just not fair, is it? No.
I know, because every year, but they want to
mastectomy because they can have immediate reconstruction as well at that young age. So they prefer doing that rather than waiting it out.
So it was offered to her, but she told no, I don't want my breasts out. And Namita, would you like to add anything? Okay. So thanks. So I just come to the end of our sessions.